of the Resident Corners module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital. The topic of today's presentation is Sylvian Fissure and Insula, which will be presented by Dr. Areeba. She is a second-year resident in neurosurgery at Liaquat National Hospital. The expert panelist today, it gives me great pleasure to introduce Dr. Jooma. He's one of my mentors from my days of training, and he's somebody who has had a great impact at neurosurgery in Pakistan. My introduction will definitely remain short to explain his contribution in neurosurgery. He has holded key positions for neurosurgery in Pakistan. Is an internationally renowned neurosurgeon. Has been one of my mentors. I welcome Dr. Jooma for this presentation. Thank you, sir, for taking our time.
Thank you, Saad.
Dr. Areeba, can you start?
Yes, sir. Assalamu alaikum. Good morning. We will be starting a session of Sylvian Fissure and Insula. It's a part of rotor neuroanatomy session. So, the Sylvian fissure is the most distinct and consistent landmark on the lateral surface of the brain. It's a complex fissure that carries the middle cerebral artery and its branches and provides a surgical gateway connecting the cerebral surface to the anterior part of the basal surface and cranial base. So as we can appreciate, this is a cadaveric dissection showing the lateral surface of the cerebral hemisphere. As we can appreciate, this would be something anterior, this would be the posterior. And we can appreciate a fissure that is present on the lateral surface, the most consistent, the most prominent fissure. This is the Sylvian fissure. It's not a simple longitudinal cleft. It crosses both the basal and the lateral cerebral surface and has a superficial and a deep part. The superficial part is visible on the surface of the brain, and the deep part, often referred to as Sylvian System, is hidden below the basal surface. So as we can appreciate, this is a frontal lobe. This is the temporal lobe. We can appreciate a fissure or a cleft that is present on the lateral surface of the brain, which is separating the frontal lobe from the temporal lobe. This fissure or this cleft is Sylvian fissure. Basically, Sylvian fissure was named after the scientist, some sister, Dr. Sylvian, who discovered it. It's basically divided into multiple small parts and a long gyre that we will be learning later on. So as we can appreciate, the Sylvian fissure has two parts. The one superficial part that was visible in the previous slide, the one we can see on the lateral surface. If we open the two upper clumps or the two parts, or if we retract the frontal part lobe above and the temporal lobe below, we can see the inside of it. And the inside is basically the deep part of the Sylvian fissure. We will go into details of these later on. So as we can appreciate, the superficial part that is visible on the surface has a stem and three rami or short branches. The stem begins medially at the anterior clinoid process and extends laterally along the sphenoid ridge between the junction of the frontal and the temporal lobes to the pterion, where the stem divides into an anterior horizontal, anterior ascending, and the posterior rami. The anterior horizontal ramus of the Sylvian fissure separates the pars orbitalis and pars triangularis, which are parts of the inferior frontal lobule, which we discussed previously. The anterior ascending ramus separates the pars triangularis from the pars opercularis. They are also part of the inferior frontal lobule. The posterior rami is the one that will continue posteriorly and end here in the supramarginal gyrus, which is part of the inferior parietal lobule. So, till now, we know that a Sylvian fissure is divided into two parts, a superficial part and a deep part. The superficial part has a long stem or posterior stem, main stem, which divides into three rami. We have an anterior ascending part, an anterior horizontal part, and a posterior rami. The posterior ramus, the longest, represents the posterior continuation of the fissure. Its posterior end runs more sharply upward to terminate in the inferior parietal lobule, where the supramarginal gyrus wraps around its upturned end, as we discussed previously. In this slide, as we can appreciate, this will be the Sylvian fissure. We can see that anteriorly, it is divided into two short rami. We have an anterior horizontal ramus and an anterior ascending ramus. We can appreciate that anterior horizontal ramus is going to divide this part, which is pars orbitalis. We can appreciate here from this part, which is pars triangularis. An anterior ascending ramus separates pars triangularis from pars opercularis. The posterior ramus is a continuation of the Sylvian fissure, and it's going to end here in the supramarginal gyrus, which is part of the inferior parietal lobule. The deep part of the Sylvian fissure, that is the one which is not visible on the surface and can only be seen once we apply the refractors, is hidden below the surface and is referred to as the Sylvian system. It's divided into a sphenoidal component and an operculo-insular component. As we can appreciate, the sphenoidal compartment would be the one which will be present inside, and the operculo-insular compartment will be superficial. The sphenoidal compartment extends laterally from the cistern around the internal carotid artery and between the frontal and temporal. Now, step-wise dissection. As we can see, we can appreciate a cadaveric brain showing the lateral surface of the brain. This will be anterior and this will be the posterior. We are viewing this brain from the right. So this will show the right side of the brain. We can appreciate a large cleft or a large fissure on the lateral surface of the brain. This is the Sylvian fissure. The part which is visible to us currently is the superficial part. If we are going to put retractors on, we can see the deep part of it. The Sylvian fissure has frontal lobe and its superior end, and we can appreciate temporal lobe inferiorly. We can see that it has a long rami that's running and it's ending in the supramarginal gyrus. We can appreciate the anterior horizontal and anterior ascending parts, rami. In the next slide, we can appreciate again the Sylvian fissure, its posterior end upturning into supramarginal gyrus, and here we can appreciate that the pars orbitalis, the pars triangularis, which were present here, have been dissected out to show their orientation or their association with the deeper structures. We can appreciate that if we are going to dissect out the pars orbitalis and pars triangularis and opercularis, we can see the deep-seated insula that is present beneath it. Further dissecting it, we can appreciate that we are going to remove all the superficial gyri of the frontal lobe, parietal lobe, and the temporal lobe that are present around the Sylvian fissure. We can see that the Sylvian fissure is a very deep structure, and it has a vascular supply, which we'll be reading later. Another interesting thing that we will appreciate here is that we can see the central sulcus, which is also present on the lateral surface of the brain on this cadaveric dissection. It will be of importance later on when we will discuss the association of central sulcus of the brain with the central sulcus of insula. So here we have another dissection, deeper dissection, which is showing the Sylvian fissure and the vessels running in it. So as we discussed previously, we have a superficial part and a deep part, and the deep part has a sphenoidal compartment and an operculo-insular compartment. So the operculo-insular compartment, as the name suggests, operculum and insular compartment is formed by two narrow clefts, an opercular cleft and an insular cleft. So the operculum cleft is situated where the Sylvian surface of the frontal lobe, that is this part, and the parietal lobes face the Sylvian surface of the temporal lobe below. So if you're going to view from laterally, so the part of the Sylvian fissure that is visible is the superficial part. Just beneath it, where the Sylvian surface or the touching surface or where the frontal lobe is kind of kissing the temporal lobe and making an opening, that surface, that part is basically the opercular cleft, an opercular opening. The deep part of the surface of the three lobes that face each other across the opercular cleft are also oriented so that they come to face the lateral surface of the insula. So as we can appreciate, this is the insula. So if we put these we remove these retractor and put the surface down. So the frontal lobe, the opercular surface of the frontal lobe and the parietal lobe will be touching the opercular surface of the temporal lobe here. So the point where they meet each other is basically a narrow opercular cleft. And if we open that opercular cleft, we can see the insula. So the opercular cleft is basically not only touching each other, that is, the opercular cleft is not only made by the opercular surface of the frontal lobe and parietal lobe and opercular surface of temporal lobe, but it is also made by the insula. So we can see the lateral surface of the insula when we open the opercular cleft. The insular cleft has a superficial limb located between the insula and the opercular of the frontal and parietal lobe, and inferior limb located between the insula and temporal. So just to make these things a little bit more clear, let me draw these things. So we are looking from the lateral surface. We are looking at the lateral surface. If we try to make a 3D anatomy, 3D picture of this, and we look at a coronal view, this would be right, this would be left, and if we consider this as the Sylvian fissure, and we make a close-up diagram of the Sylvian fissure, so it will be like this. We will have frontal lobe here, and we will have temporal lobe here. So the part of the frontal lobe which is making the opercular surface or the opercular surface, this, and the part of the temporal lobe which is making the operculum, this part is the opercular cleft. If we are going to put retractors here, the part that we are going to open, this is insula. So the part we are going to open, the space we are going to open, this is basically the insular compartment. Yes, sir. So this will be the insular compartment. Okay, sir. So if you're going to take it a little bit, make it a little bit clearer, so it will be something like this. So this part will be the opercular part. This whole space will be the insular space, and this is going to be the insula. So the opercular cleft is situated where the Sylvian fissure of the frontal lobe and the parietal lobe face the Sylvian surface of the temporal lobe below. And the insular cleft has a superior limb located between the insula and the opercular of the frontal and parietal lobes, and an inferior limb, this, located between the insula and the temporal operculum. So up till now, we have discussed that the Sylvian fissure has a superficial part which has a posterior rami, to an anterior ascending rami and anterior horizontal rami. Then we have two deep parts of the Sylvian fissure. We have an sphenoidal compartment which is present very deep. We have an opercular insular compartment. The opercular insular compartment itself is composed of two parts, an opercular cleft and an insular cleft. Another picture showing a better view. We are looking at a coronal view. We can appreciate that this is the right side of the cadaveric brain, and we are viewing from front. We can appreciate the olfactory tract and the midline structures. And as we can see, this is the Sylvian fissure on the surface. And this is actually Sylvian fissure, which is deep inside. So it's a bigger picture, it's a bigger thing. So the Sylvian fissure present on the superficial surface has a rami, posterior rami and two ascending rami. This will be the Sylvian surface of the frontal lobe. This will be Sylvian surface or the opercular surface of the temporal lobe. If you are going to put retractor here and here, we will open this space. This space will be the insular cleft. This will be the superior limb of the insular cleft. This will be the inferior limb of the insular cleft, and this part will be the insula. If you are going to go deep in it, we will see the sphenoidal compartment of the Sylvian fissure. So
Areeba?
Yes, sir.
Areeba, this Dr. Jooma here. So Areeba, this is a basal view that we've got. It's not a coronal view.
Okay, sir.
So we're looking at the Sylvian fissure from inferiorly, you're looking at the stem of the fissure from the inferior aspect. So that's the beginning.
And so this will be anterior and this will be posterior.
So this is like the door or the entry point of the fissure, if you like.
Okay, sir.
The rest of what you said is absolutely right. It's just that for orientation, it's not a coronal view, it's a basal view. Please go ahead, Areeba. Please go ahead.
Okay, sir. Thank you, sir. So the upper lip of the opercular cleft is formed by the gyri of the frontal and parietal lobes that continue medially around the upper edge of the fissure to form the roof of the Sylvian system. And from anterior to posterior, the pars orbitalis, triangularis, opercularis, and pre-central, post-central, and supramaxillary gyrus. A better picture of it was present here. So, as we can see, this will form the roof of the insular cleft, and it will be formed by pars orbitalis, pars triangularis, pars opercularis, and the supramarginal gyrus. The lower lip of the opercular cleft is formed from posterior to anterior by the planum temporale, composed of the transverse temporal gyri, the most anterior and longest of the Heschel gyri, which we discussed previously in the temporal lobe, and the part of planum polare lateral to insula. Now coming to the insula, which is present deep to the Sylvian fissure. The insula is a triangular shape with its apex directed anterior and inferiorly towards the limit insula, a slightly raised area overlying the uncinate fasciculus covered by a thin layer of gray matter at the lateral border of the anterior perforated section. So it's basically a triangular structure, some people previously used to call it a lobe, a fifth lobe, which was present on a deeper surface. The lumen is located at the junction of the sphenoidal and operculo-insular compartment of the Sylvian fissure, as we discussed previously, that if we are going to dissect out and retract the frontal lobe and the temporal lobe, the lumen insula is located at the junction of the sphenoidal compartment and the operculo-insular compartment of the Sylvian fissure. The insula is encircled and separated from the frontal, parietal, and temporal opercular below by a shallow limiting sulcus. So there is a sulcus that is separating it from the frontal lobe, parietal lobe, and the temporal lobe below. The limiting sulcus, although it's roughly triangular in shape because the insula is triangular in shape, to confirm the shape of the insula is commonly referred to as circular sulcus because it encircles the insula. So although the insula is triangular and the sulcus, which is limiting sulcus, is running around it, is triangular in shape, it is called circular sulcus because it encircles the insula. So this sulcus that is running around it will be the circular sulcus. The sulci and gyri of the insula are directed superiorly and posteriorly in a radial manner from the apex at the lumen insula. The deepest sulcus, the central sulcus of the insula, is a relatively constant sulcus that extends upward and backward across the insula, nearly parallel and deep to the central sulcus of the convexity. So as we discussed previously, now in this diagram, in this cadaver dissection, a part of the frontal lobe, which was covering the, making the operculum, has been removed to show the association. As we can see that the central sulcus, the main sulcus of the insula, is running superiorly and posteriorly, and it is somewhat parallel to the central sulcus of the surface. It divides the insula into a large anterior part that is divided by several shallow sulci into 3 to 5 short gyri, and a posterior part that is formed by the anterior and posterior long gyri. So as we can appreciate, we will have a circular sulcus or a central limiting sulcus that is going to encircle the insula. There will be a deep sulcus, central sulcus, that will divide the insula into an anterior part and a posterior part. The anterior part will have 3 to 5 short gyri, which are going to divide insula into 2 to 4 different fissures, divided by different fissures. And the posterior part has long gyres, which is basically we have a posterior part which is formed by a long gyre, anterior and posterior long gyres. The insula covers the lateral surface of the central core of the hemisphere core, formed by the extreme, external, and internal capsule, claustrum, lentiform nucleus, and chordate nucleus and thelemi. As we previously saw in a diagram in the previous lecture, that the central core formed by the internal capsule and the chordate nucleus, and then putamen, lentiform nucleus, that is putamen globus, they laterally had the extreme capsule, and then they had an area called claustrum, and then we have extreme capsule, and that we had insula. So basically, if we are going to see from superficial to deep structures, we will have Sylvian fissure. Once we open it, we will see insula. So once we see insula, the insula is basically covering the lateral surface of central core of hemisphere, formed by the extreme capsule, external capsule, internal capsule, the claustrum, the lentiform nucleus, and the chordate nucleus and thelemi. Just a step-by-step dissection of what we read before. We are looking at the lateral surface of the cadaveric plane, and we can appreciate the Sylvian fissure, the Sylvian system. Another thing to notice here is when we look at the Sylvian fissure laterally, we can appreciate that the pars which is present here, that's pars triangularis, this part of the Sylvian fissure is a little bit broader or wider as compared to the opening here. So this part, the part below the pars triangularis, this wider channel basically provides an opening for the Sylvian fissure. Now moving on forward, we have removed the opercular compartments and we can appreciate the insula. We know that the sulcus that is encircling or is running around the insula is known as the circular sulcus. We can appreciate main sulcus or a deeper sulcus that is present on the surface, which is somewhat parallel to the central sulcus that is running on the surface, and this is known as the central insular sulcus. It's going to divide this insula into an anterior part and a posterior part. As we appreciated previously, an anterior part is divided by 3 to 5 gyri, and the posterior part has an anterior and a posterior long gyri. Similar diagram, but with labeling, we can appreciate a central insular sulcus. We can appreciate these small 3 gyri. We have an anterior short gyri, we have a middle short gyri, and we have a posterior short gyri. All of them joining here at the apex. The part of the central sulcus that is anterior to it will be the anterior limiting sulcus or anterior circular sulcus. The part of the central sulcus or the limiting sulcus that will be present here will be the superior part. The part will be present here will be inferior, and this will be the posterior. As we can appreciate, the central insular sulcus is divided into anterior and posterior part, and we can see the posterior long gyri and anterior long. So to summarize this up, we have a clear picture of insula here. We know that insula is surrounded by the circular sulcus. Circular sulcus is, again, if you try to divide it, we can divide it into an anterior part of the circular sulcus, a superior margin of the circular sulcus, a posterior margin of the circular sulcus, and the part where they are all joining and there is no gyri is basically limit insula. We can see that there is a central sulcus, which is dividing it into an anterior part and a posterior part. Anterior part has 3 to 5 short gyri. So here we have an anterior short gyri, a middle short gyri, and a posterior short gyri joined together at apex. We can see that posterior part has an anterior long gyri and a posterior long gyri only. So again, similar picture and a better magnification. And I hope it's clear by now. So how are these insular structure association, or what is their importance? So as we can appreciate in these slides, that if we are good, we can appreciate that this would be somewhere here would be the insula that we have dissected in half. And as we can appreciate, this is central insular sulcus. So this would be running somewhere here. This is the posterior part where we have long gyri, and this is the anterior part. And if we are going to dissect the anterior part, we can appreciate it is lying lateral to, or it's covering the lentiform nucleus and the foramen of Memon. Similar diagram, dissecting it out further. Here we can appreciate that the Sylvian fissure, if we are going to see it on lateral surface, is basically covered. Here we have just the frontal operculum retained, and we have put a refractor on the temporal operculum or the temporal surface. We can appreciate that this insula has an association, or it's touching the opercular component, opercular surface of the temporal lobe, which we previously discussed is formed by the planum temporale, Hash's gyrus, and the planum polare. Magnified view of the insula showing the association of Hessel gyrus, which is present on the temporal surface, temporal operculum to the insula, which we discussed previously. So again, another diagram of the insula showing the association of and the joining of the anterior short gyri, the middle short gyri, and the posterior short gyri, which are all part of the anterior surface of the insula, which is divided from the posterior surface by the central insular sulcus. And as we can see, the point where they all join is the apex. So the upper margin of insula is located superficial to the mid-level of the body and head of caudate nucleus. So the upper margin of insula is located superficial to the mid-level of the body and the head of the caudate nucleus. The posterior segment, superior segment of the angle of insula is the site of Sylvian point, is situated superficial to the anterior margin of the upper part of atrium, with the crus of fornix wraps around the pulvinar. The majority of the atrium is located behind the level of posterior superior part of circular sulcus. A surface landmark paralleling the lower border of the insula is the superior temporal sulcus, and a deep landmark paralleling the lower border is the optic tract, coursing in the roof of ambient cistern near the midline, which we can appreciate here. So the lower border of insula is marked by the superior temporal sulcus, and a deep landmark that we can appreciate that if we are doing dissection that we have reached the lower part of insula is the optic tracts coursing the ambient cistern near the midline. So this will act as a lower border of insula, and a dissection from the head of caudate, this will act as the superficial part of the insula. So insula is always lying here in this part. So just before we end our presentation, let's ask a few questions regarding the anatomy that we did before. Can you, Dr. Saad, can you conduct this part?
Yeah. So I want all the participants to use the chat box. Dr. Areeba has marked some structures for you. Can you name this the structure that is marked in blue? So Dr. Pravat is saying this is the horizontal ramus. The anterior, I think he means the anterior horizontal ramus of the Sylvian fissure. Let's see what the other people are saying. So we just have response from Dr. Pravat, and he thinks that this is the anterior horizontal ramus. Dr. Areeba?
Yes, sir. It's the anterior horizontal ramus. This will be the anterior ascending ramus, and this will be the posterior rami.
Okay, move on. So, which part of the superficial is this? So this is the most of them are saying this is the posterior MI.
Yes, sir.
Okay.
Here we have exposed the insular surface, and we can see the insula here. The frontal operculum and the temporal operculum have been retracted.
Okay. Dr. Areeba?
Yes, sir. It's the central sulcus.
Yeah.
It's the central sulcus of the insula, and it's dividing insula into an anterior compartment and a posterior compartment. Anterior compartment is composed of 3 to 5 short gyri, and posterior compartment is composed of anterior and posterior long gyri. So this is an MRI brain coronal view showing the Sylvian fissure, which structure is labeled in green here.
So which structure? So Fawaz is saying that this is the insula. Dr. Pravat is saying that this is the claustrum. Dr. Areeba, what do you think?
So this is insula. As we can see, this is the Sylvian fissure. So when we will open it, it will be the insula. This structure that will be running lateral to it will be the extreme capsule. Then the part that will be medial to it will be claustrum. Then we will have the external capsule. Then we will have the lentiform nucleus, internal capsule, and the caudate and thalamus. That's it. Thank you, sir.
So thank you, Dr. Areeba, for your presentation. I will now request Dr. Jooma for his expert opinion, or maybe if you have a case to share.
So thank you, Areeba, for that exposition about the anatomy of insula, which quite honestly is a little complicated because like a lot of body structures which have been inverted, and I can remember as a medical student struggling endlessly with trying to understand the peritoneum because it's folded in. And as it unfolds, it assumes a very complicated configuration. And the insula is a bit like that. But more recently, it's become quite important because of glioma surgery. And, I want to make the point, Areeba, that for the surgeon, the parts of the insula or the parts of the various sulci that you pointed out are less or more important depending on how you do your surgery. And what I mean by that is, for the people who open the Sylvian fissure from back forwards, the short sulci around the stem are probably less important. But for the people who open the Sylvian fissure from proximal to distal, which means opening the stem first, for them understanding or having an appreciation of the sulci up in front is probably of greater importance. Having said that, I'm also I think that it would have been nice, but it's such a complex subject, and maybe you can do this as a part 2 to the insula. This insula is important for many reasons, but the most important is because it harbors the Sylvian, the middle cerebral artery complex. And one of the reasons that I think it's better to come to the Sylvian fissure from distal to proximal, because there's one very critical artery in the front, and that's the first lenticular striate artery. And the first lenticular striate artery takes off just before or after the bifurcation, and spends a few millimeters in the fissure before it dives into the brain. And injury to that is an absolutely devastating problem with a dense hemiparesis, which really doesn't recover too well because it burns up the internal capsule at the important genu point. So I think maybe the next time round we can get you to speak about the vessels, the long and short vessels, the perforating vessels, the trunks, the upper trunk, the middle trunk, and exactly where they lie in the Sylvian fissure. Because if you're going to do Sylvian fissure surgery, you need to have a very good understanding of what lies where. So number one, you know where to find them, but more important, you always have orientation and are not confused between, I wonder what this vessel is and I wonder what that vessel is. Because a lot of insular glioma surgery, quite frankly, is done between these vessels. And so having a good understanding of that is probably quite important. I could say much more about the surgery, and I'd like to on another occasion, because insular surgery is something that I've been looking at for many years now. And I'm really delighted to see the way it has evolved and assumed sort of mainstream practice from the time that Yashagil started alerting us to the possibility of operating on the insular tumors many years ago. So, Saad, that's what I have to say. And congratulations to the team at Liaquat National for putting on this really very interesting. And I'm a little disappointed that there aren't more residents from Pakistan on this webinar. But then maybe it clashes with ward duties and stuff like that, which I think Salman needs to look at in terms of time, although I can't see what other time can be better than this. So I good luck to you, and I'd be very happy to join in and talk about the surgeries of insular glioma at a later stage.
So, thank you, Dr. Jooma, for your time. And next week, we will be discussing the surgical process to open up the Sylvian fissure and for surgery of insula. So we'll like to have you there next week as well, if possible.
Yeah, sure, absolutely, and absolutely. I'll be there with you at 7:45 next week.
Okay, thank you, Dr. Jooma. Thank you, Dr. Areeba, for this excellent presentation. We'll see you all next week. I thank you all for joining.